part I love to, so if you want me, I'll be happy to.
Yeah, please, yeah, this is
So good morning, everyone, and thanks for joining us this morning. You are the lucky ones to come early to see some of the best parts of this, which is the chronic total occlusions. So we're going to start this session, which is entitled All You Wanted to Know About Treating Complex Angiographic Subsets, with Dr. Farouc Jaffer from Mass General Hospital in Boston, who's going to give us an overview on the current management of coronary chronic total occlusions.
Good morning. Thank you very much for the invitation and the introduction. It's a pleasure today to speak on chronic total occlusions in this very exciting session this morning. These are my disclosures. I also would like to acknowledge Dr. Bill Lombardi for some of the slides in this presentation and in general for being a thought leader and guiding us and many of us into the CTO area to really build programs. So just to define this entity, this is a complete occlusion of a total artery, TIMI 0 or TIMI 1 flow, and it's aged greater than or equal to 3 months old. This is a frequent finding. It's a population in need. 18% of patients undergo angiography will have a chronic total occlusion. Now, remarkably, many of these patients are quite symptomatic, and yet a few of them will actually be attempted for percutaneous coronary intervention. And this is really where our disconnect has been in this field, where we have effectively, once we've seen a total occlusion, as soon as we see it, we've turned our minds off and really think that it has not been an approachable subset historically. So in terms of thinking about specific things for angiography, what is actually different, for example, than just conventional diagnostic angiography in terms of obtaining information that is going to be useful for percutaneous coronary intervention? So the most important area is to really visualize collaterals. And there are two ways to do this, of course. We usually just place one sheath during diagnostic catheterization, but at times it can be very, very important to place a second sheath. This can often be done radially to minimize the amount of invasiveness. Another particular technique that can be used is to upsize to a larger guide and place 2 diagnostic 4 French catheters to inject both the left and right coronary. It's important to realize that when one looks for collaterals, especially for septal collaterals to connect the LAD to the right coronary, that an unpanned angiogram is very, very important. We're typically panning, looking for the larger collaterals, but for looking for fine microchannels, an unpanned angiogram is very, very important to really see that fine detail.